could a primary care physician diagnose MCAS in the community?
Okay. So obviously, as I said before, taking a history with and while taking the history, try to keep in mind what we were discussing about how MCAS presents. There's 2 points I'd like to make. One is in terms of laboratory testing. The tests that I mentioned, histamine, tryptase, chromogranin A, and prostaglandin D2, they're not easy to run. Quest runs them, LabCorp runs them. If they're not properly processed by the lab tech, they rapidly decline in levels. They get rapidly metabolized down. And that's specifically particularly true for the histamine and the prostaglandin D2. Okay. So if they're not ideally drawn into a chilled tube, immediately spun, immediately aliquoted, and then frozen. If you get a normal level and it wasn't processed right, you can't really believe that normal level. Okay. In general, there's no lab that does what I just said. So I still try to order those tests and I would urge other physicians to order them. But if they come back normal, keep in mind one of the things you learned in school, if you have a clinical suspicion, that may trump labs, whether they're abnormal or normal, okay? And sometimes you repeat them. Maybe you can talk to the lab and try to get them to at least freeze it more quickly or spin it more quickly. Tryptase almost always in mast cell patients actually comes back normal, which goes against everything we were all taught. So I actually sometimes don't even order it just to save money. Okay. Chromogranin A is a great test because it doesn't need to be frozen. So if that comes back abnormal, it may be your best signal that your clinical suspicion is correct. The other lab tests that can be very helpful if at any time the patient has had upper or lower endoscopies and biopsies were taken for whatever reason, those are usually samples kept in the path lab for 5 to 7 years. You can request CD117 staining, which stains from mast cells, and ask them to count. This is the part you got to very specifically tell the pathologist. Count the number of CD117 positive cells per high power field. This has nothing to do with aggregation, which is what they think you're looking for. It's just a number. And the general accepted upper limit of normal is 20. So if you see more than 20 in a high-powered field, that's another laboratory confirmation, histology confirmation of MCAS. That's one way. So history, testing. And the third way, which I think is in many ways the most important way, is a trial of medicine. Something we do in medicine all the time. Doctors do it all the time, but for some reason they don't like to hear this idea. Just say, hey, I think maybe you have MCAS. Let's just try an histamine 1 receptor blocker like cetirizine and a histamine 2 receptor blocker like famotidine or Pepcid and Zyrtec are their brand names. Take them twice a day. I recognize that's twice the dose on the bottle for cetirizine, but take them twice a day and see what happens. Those drugs do not cause side effects, almost never. They're very cheap. You don't even need a prescription. And over and over and over, a patient will say, my brain fog cleared up. It's the weirdest thing from an antihistamine, or I can eat foods without getting sick. So a trial of therapy and a response to therapy is very compelling for the diagnosis.